This is our first video in pharmacology topics for finals. It represents an enormous area of medicine. It also represents an enormous area of dread for medical students. And at this stage of exam revision in 5th year or even 4th year, for some of you who are revising for your finals in 4th year, you should be able to, the topic should be able to be asked of you in a way where you're prepared to answer questions about any drug on your formulary in any order. And this is what these videos aim to help you do. I've written these questions for my own finals group at university, and we'll discuss the answers of them during this video. The first thing to mention is that drug questions like this may not come up like this in a written paper, but they certainly do come up like this whenever the examiner asks you specific questions about drugs. They also come up in real life, and you should know what pretty much all of these things do. They're taken from my own formulary, which I kept from whenever I was at medical school. So these things are not things that I would expect only seasoned senior physicians to sort of remember, but these are things that you should know in medical school. So let's start with question 1. What is the stepwise progression of asthma treatment in general practice? Now, this refers to, if you're in the UK, for example, the BMJ have a wonderful stepwise progression algorithm for the treatment of asthma in general practice. The whole goal of treatment of asthma in general practice is to achieve maximum control of symptoms with the fewest medications. Asthma control refers to the extent to which the manifestations of asthma have been reduced or removed by treatment. An optimal control should include assessment of a combination of the patient's symptoms and the pulmonary function testing. However, we're not going to go into that here. We're going to spend some time talking about the drugs. So we're going to be answering this question by looking at the British Thoracic Society document from the link that is posted to the right of the picture. That is from their consensus document published in 2016. It's an excellent document dividing asthma, the treatment of asthma, into suspected asthma and diagnosed asthma. So if you look at the suspected one, this is always after an evaluation, as mentioned at the top of the diagram here. You should consider a monitored initiation of treatment with a low dose inhaled corticosteroid, such as the puffs of beclomethasone, for example. Once you've diagnosed the asthma, you add a regular preventer inhaler in, such as the low dose inhaled corticosteroid, as we've already said, and then you should have short-acting beta-2 agonists as required throughout the stepwise progression. Here you see that band at the bottom of the diagram saying short-acting beta-2 agonist as required. So you should always have that. So your first thing is your short-acting beta-2 agonist, and then adding on your low-dose inhaled corticosteroid. Your first step up is your initial add-on therapy, which is where you're adding an inhaled long-acting beta agonist such as salmeterol to low-dose inhaled corticosteroid, and that normally is a combination inhaler. And you need to know what the combination inhalers are. A combination inhaler example is Seretide, and Seretide comes in a variety of different strengths. It's a purple inhaler, and it contains fluticasone and salmeterol in it. So then moving on from that, your additional add-on therapies, which in your diagnose section is step 3. If you've no response to the long-acting, you stop it and consider increasing the dose of inhaled corticosteroid. If there is benefit from the long-acting beta agonist salmeterol, but the control is still inadequate, you continue the long-acting beta agonist and increase the inhaled corticosteroid dose to a medium dose. If there is benefit from your long-acting beta agonist but control is still inadequate for the patient, you continue the long-acting and the inhaled corticosteroid and consider a trial of other therapy. And it says LTRA, and that's leukotriene receptor antagonists such as Montelukast, or slow-release theophylline. And the last drug it mentions there is a LAMA and LAMA, which is a long-acting muscarinic antagonist, and an example of that is tiotropium. Moving on to the high dose therapies, you should consider trials of increasing your inhaled corticosteroid up to a high dose, so that's 2,000 micrograms a day or something like that. Addition of a fourth drug such as a leukotriene receptor antagonist like Montelukast again, slow release theophylline, a beta agonist tablet, or a long-acting muscarinic antagonist such as tiotropium again. You should refer the patient for specialist care at this point. And then further on to that, you can use a daily steroid tablet like prednisolone in the lowest dose possible to provide adequate control. You maintain those high dose inhaled corticosteroids, the beclomethasone or fluticasone, for example, and consider other treatments to minimise the use of steroid tablets. But this is all in the realms of specialist care, and this provides a really good example of what your stepwise algorithm in general practice should be. The next question is, what does Montelukast do? Montelukast is also known as the trade name Singulair. It's a leukotriene receptor antagonist, or an LTRA. It's used for the maintenance treatment of asthma and to relieve symptoms of seasonal allergies. Montelukast, it comes as a tablet, a chewable tablet, a flash tablet, or granules to take by mouth. It's usually taken once a day with or without food. It blocks the action of leukotriene D4 and secondary ligands on the cystenyl leukotriene receptor. This receptor is in the lungs and the bronchial tubes, and it does that by binding to it. This binding reduces bronchoconstriction that otherwise caused by the leukotrienes, and results in less inflammation. So it basically reduces the bronchoconstriction because it blocks the receptor site that the leukotrienes would normally act on, therefore blocking their action and therefore resulting in less inflammation. Because of its mechanism of action, it's not actually very useful in the treatment of acute asthma attacks. Just as a bit of information, the Mont in Montelukast stands for Montreal, which is the place where Merck developed the drug. So some additional information. These cystenyl leukotriene receptors, they're present on mast cells, eosinophil and endothelial cells. So during cystenyl leukotriene interactions, they can stimulate pro-inflammatory activities such as endothelial cell stickiness, adherence, and chemokine production by mast cells. As well as mediating inflammation, they induce asthma and other inflammatory disorders. Therefore, they reduce the airflow to the alveoli. The levels of cystenyl leukotrienes, along with a couple of other things, have been reported to be increased in patients with asthma, correlating with disease severity. So the more severe disease you are, the more likely you are to have these cystenyl leukotrienes. So that's why it actually is useful to downregulate their effects by blocking their receptors. So the next question is, name the relative and absolute contraindications to non-steroidal anti-inflammatory drug therapy. So you need to ask yourself how non-steroidal anti-inflammatory drugs work. They work to reduce pain and inflammation by inhibiting enzymes that are called cyclooxygenases, or the COX system, and by inhibiting COX, non-steroidal anti-inflammatory drugs help to prevent and or reduce pain and inflammation. COX enzyme inhibition is also responsible for many of the side effects of non-steroidal anti-inflammatory drugs. Most of the side effects are relative in nature. Absolute contraindications include things like allergy and patient refusal. Relative contraindications, however, to NSAIDs are if you are, for example, hypertensive. The addition of either a selective or non-selective non-steroidal drug to the medications taken by somebody with hypertension can result in a loss of blood pressure control. If non-steroidals are required, they should be used at the lowest effective dose and for the shortest duration necessary. In cardiovascular disease, anyone who's at risk of cardiovascular disease may have further increase in risk of heart attacks when taking a non-steroidal. This includes people who have experienced angina or stenting or strokes or ischemia within the brain. As a result, people who have or are at high risk of coronary artery disease are generally advised to avoid non-steroidal drugs. If that's not possible, you take the lowest possible dose of the non-steroidal for the shortest possible time. Although aspirin is a non-steroidal anti-inflammatory drug, the recommendation to avoid or limit the use of non-steroidals does not apply to people who have been advised to take low-dose aspirin. So that's just something to mention. It's also contraindicated in ulcer disease if you've had an intestinal ulcer, if you're at bleeding risk. So if you have problems with ulcers in your stomach and you have it bleeds from varices, upper intestinal or esophageal bleeds, you have an increased risk of recurrent bleeding when taking non-steroidal anti-inflammatory drugs. If you have a platelet disorder such as von Willebrand's disease, abnormal platelet function from uremia, or low platelet count in general, such as thrombocytopenia, you're advised to avoid non-steroidal drugs. You would probably advise patients before surgery not to take non-steroidals, and we normally advise stopping them approximately 1 week before elective surgery to avoid the risk of excessive bleeding. If you're on warfarin or heparin, you should probably curtail your use. Aspirin, the combination of low-dose aspirin and a non-steroidal anti-inflammatory drug may increase the risk of bleeding. If you're taking phenytoin, you should probably curtail your use of non-steroidals if possible, because non-steroidals can increase your phenytoin level. Cyclosporine, if you take a cyclosporine, you should take particular care when taking your non-steroidal anti-inflammatory drug, because there's a theoretical risk of kidney damage when cyclosporine and non-steroidals are taken together. And people taking one non-steroidal drug should not take a second drug at the same time because of the increased risk of side effects. So if you're on naproxen, you wouldn't take diclofenac as well. It also goes to say that if you have an allergy to any non-steroidal, you should probably take them with caution. And if you've got kidney disease, non-steroidals can worsen your kidney function in those people whose kidneys are not functioning normally. Most people with chronic kidney disease are advised to avoid all types of non-steroidal anti-inflammatory drugs, and indeed that probably carries through into renal medicine. They don't advise very many people take non-steroidal medication. Next question is question 4. It's name the clot-busting drug that's used in embolic or infarctive stroke lysis therapy. So the drug used here is commonly known as alteplase. It may be referred to as recombinant tissue plasminogen activator, or RTPA. Tissue plasminogen activator is abbreviated TPA. TPA is a protein involved in the breakdown of blood clots. It is a serine protease found in endothelial cells, the cells that line blood vessels. And as an enzyme, it catalyzes the conversion of plasminogen to plasmin, the major enzyme responsible for clot breakdown. Because it works in the clotting system, TPA is used in clinical medicine, stroke medicine, to treat embolic or thrombotic stroke. You would not use this in hemorrhagic stroke and head trauma, and the antidote for TPA in case of toxicity is aminocaproic acid. The other drug that is the opposite of TPA, said to be the opposite of TPA, is tranexamic acid, which stabilizes clots. So the next question is, in increasing potency, name the main steroid creams used in dermatology. So I'm going to use this from a UK perspective. I'm going to use the brand names of them as well. There's quite an easy way to remember it. It's just hydrocortisone, Umivate, Betnivate and Dermavate in escalating potency. So hydrocortisone is mild, Umivate is moderate, Betnivate is potent, and Dermavate is very potent or super potent in your 4 classes. And I would stick with keeping these 4 in your mind. There are so many more creams, you can look them all up, but those are the 4 that I would keep in mind for escalating potency. So the next question then is name a first-line antibiotic in chest infections in GP. So you're assuming then that the chest infection is a community-acquired pneumonia. If the person's had a recent hospital admission, that's a different thing altogether. However, for community-acquired pneumonias, pneumonia is typically an acute febrile illness with cough, breathlessness, often productive of sputum, but a pleurisy, pain in the chest, and patient with or without existing chest disease. There could be new shadowing on a chest x-ray. So you're going to use your CURB 65 score, which is confusion, urea greater than 7, respiratory rate greater than 30, blood pressure less than 90 systolic or less than 60 diastolic, age greater than 65, and that's your CURB 65 score, so don't forget it. If you are CURB 0 to 1, you would start them on amoxicillin, 500 milligrams to 1 gram, 8 hourly orally. If they're CURB score 2, you would give them amoxicillin or something similar, 1 gram, 8 hourly, either intravenously or PO, well as clamithromycin, 500 milligrams, 12 hourly IV. But this, by that stage, would be hospital. So in terms of the initial question, for a low CURB score person in the community, you might start them on amoxicillin, 500 milligrams, 1 gram, 8 hourly. As always, these doses are not to be used for prescribing. This is an informational video, and you should always consult your local prescribing formulary or and particularly your local antimicrobial guidelines. And so without repeating what we've talked about there, we're going to answer number 7. Name a first-line antibiotic in a penicillin allergic patient to treat chest infection GP. So community-acquired pneumonia, same thing about the CURB 65. Appropriate antibiotics might be something like doxycycline, 100 milligrams 12 hourly PO, escalating then in hospital to maybe levofloxacin intravenously, still clarithromycin, and further on you might add in something like metronidazole if you suspected an aspiration pneumonia, but you would also add in metronidazole if you suspected an aspiration pneumonia in somebody who was not penicillin allergic. So it's the same principles but just slightly different antibiotics. So just don't give anything with penicillin in it. That includes tazocin, which is piperacillin. Just be careful about your antibiotic crossovers and always consult an antimicrobial guidelines. All of your hospitals should have one. It makes it very easy for you these days. So the next question is about the role of aminophylline and theophylline in COPD. So it's been used as a bronchodilator in the treatment of COPD for over 70 years. It's lost popularity recently because there are better tolerated and more effective bronchodilators out there. It's sort of relegated into the third line bronchodilator after inhaled anticholinergics such as tiotropium and beta-2 agonists such as salbutamol, salmeterol. Salmeterol doesn't really get used in COPD, however. It's recognised that theophylline is useful treatment in the patients with severe COPD, and you can see that because its withdrawal in patients leads to significant clinical worsening of the disease. Traditionally it was the bronchodilator of choice, but it was associated with whenever you were at therapeutic concentration of theophylline, which is traditionally why you have monitoring of theophylline, you had really bad side effects and people didn't really like it. It has quite a lot of non-bronchodilator effects because the clinical benefit from theophylline at doses that give a plasma concentration well below that needed for bronchodilation still give benefit. And that suggests that theophylline must have some additional benefit. This is exemplified by the worsening of disease control whenever it's withdrawn, and it has inhibitory effects on airway inflammation in COPD, and these are seen at plasma concentration levels below 10 milligrams per litre. This is particularly good because corticosteroids have no demonstrable anti-inflammatory effects on the same parameters that are looked at in COPDs, even at high doses. And there are a number of papers recently that have confirmed this. The low-dose theophylline significantly reduces sputum neutrophils, etc. So anti-inflammatory effects and bronchodilators. It also helps in diaphragmatic contractility that helps with work of breathing. However, the short answer for all that is, it is a phosphodiesterase inhibitor that is used in COPD treatment, severe COPD treatment, usually after salbutamol and antimuscarinics have been used as well. So what blood tests do people on phenytoin require? The first thing I'm going to tell you are the signs of phenytoin toxicity, and they are drowsiness, ataxia, mental changes, confusion, nausea, hyperglycemia, slurred speech, nystagmus, and coma. These are signs of phenytoin toxicity, and if you see those, you'll need to do a phenytoin level to make sure that the patient is not toxic. But this question probably refers to what blood tests do people on phenytoin require whenever you're starting off people on phenytoin in the hospital. There is a difference between IV and bolus dosing. Phenytoin is highly bound to albumin, so always check an albumin level in somebody you're about to start phenytoin on, and that would usually require doing a liver function test. Make sure their liver function is good because that will also affect the metabolism of phenytoin. And lastly, I suppose liver damage and hematopoietic disorders have been associated with phenytoin. Therefore, baseline liver function tests and full blood counts should be taken when commencing phenytoin treatment. They should be repeated monthly for the first 3 months of treatment and 6 monthly thereafter. This differs depending on what cohort you're in the hospital. If you're in intensive care, for example, and your liver enzymes could be playing havoc with yourselves, you might want to be doing daily phenytoin levels, and you're going to be already testing daily FBCs and stuff like that. But in normal patients who have been starting phenytoin, the guidelines would be that you do monthly tests for liver damage and FBC for the first 3 months of treatment, and then 6 monthly thereafter. So our final question, name 3 alternative anti-epileptic drugs other than phenytoin. There are so many anti-epileptic drugs across the world. We should go by their generic names, but if you're prescribing them, you should prescribe drugs with their actual brand name. So if you're thinking about things like Keppra, which is levetiracetam, and Epilum, which is sodium valproate, but there are so many more. There's acetazolamide, carbamazepine, clobazam, clonazepam, ethosuximide, gabapentin, lacosamide, lamotrigine, levetiracetam, like we said, Capra, nitrazepam, phenobarbital, phenytoin, as we already have used, you can't use it again, pregabalin, primidone, sodium valproate, which is Epilim, topiramate, vigabatrin, and there are probably a lot more aside that. So if you're only asked to get food, that's perfect. But the mainstays of treatment are things like carbamazepine, phenytoin, Capra, which is levetiracetam, and Epilim, which is sodium valproate.